Our faculty for today is Dr. Gautam Das. He has done his MD, MRCP, Diabetes and Endocrinology, FRCP and FACE. He is the consultant physician and endocrinologist in University of Hospital of Wales, Cardiff and Vale, and also University Health Board, Cardiff, United Kingdom. Thank you.
So the format remains the same. So this is of course part of the modular course for MRCP part 1, and we take this turns to discuss around 20 odd questions which may be of relevance for you, of significant relevance to you, covering different aspects of the topic, and you may encounter very similar or related questions in your exams. So the format what I have done before and the current format would remain the same. So I'll put up one such questions, and then I'll give you around 10 seconds to go through the choices, and then you make a note on your individual notebooks or whatever, and then we'll discuss the answer and the questions very briefly, just to give you a flavor. So as said, I work as a consultant endocrine in Wales, which is part of UK. And I've been a consultant for almost 10 years, having been in UK for 20 years. So let's go through. So the first question is about diabetic foot ulcers. So so the question is, which of the following is true regarding diabetic foot ulceration? So choice A, autonomic neuropathy results in increasing resting blood flow. Skin infection is the most common initiating event in ulceration. Callus formation at pressure areas is an important predictor of ulceration. Plantar ulceration is most commonly due to peripheral vascular disease, and radiography can easily distinguish between Charcot's arthropathy and osteomyelitis. So have a read through the choices again, and then make a note of the answer yourself, and then I'll take you to the next slide, the answer as the next option. So 10 seconds. Diabetic foot ulceration is quite common in the MRCP exam, and you'll get probably questions on individual stems as well. Yeah, so I hope you have got your choice there. So the answer here is C. Callus formation at pressure areas is an important predictor of ulceration. So foot ulcers in diabetic people or in patients, we don't use the term diabetic anymore. It's patients with diabetes. So foot ulceration in patients with diabetes is often due to mixed etiology. So primarily it is due to peripheral neuropathy. Patients may often have peripheral arterial disease, or it may be a combination of both. Plantar ulceration is most common in foot disease, and it is usually as a consequence of peripheral neuropathy, and any minor skin trauma or chronic skin condition like callus formation overlying bony prominences would be probably the most common initiating event. And because patients don't recognize those trauma because of foot deformity and due to peripheral neuropathy, invariably grade 1 ulcers can develop into grade 4 ulcers very soon. Blood flow is often decreased in autonomic neuropathy in these circumstances. So if I take you through the individual stems, autonomic neuropathy actually results in reduced blood flow. Skin infection is often not the most common initiating. It is the microtrauma or callus. And plantar ulceration is often due to a combination of peripheral neuropathy and vascular disease, so not due to peripheral arterial disease alone. And radiography is not often helpful in differentiating the two unless you do a detailed MRI scan. So that's the answer. Callus formation at pressure areas is an important predictor of ulceration. If you have any questions, please put it in the chat or raise your hands, then we will go through it. So question 2. So this is probably just to reiterate the risk factors for diabetic foot ulcers. So it is much more common in men because they're usually smokers. Long duration of diabetes, of course, leading to peripheral vascular disease and microvascular complications like peripheral neuropathy. If patients have previous history of ulceration, the risk is high. If you've got vascular disease, of course, or previous history of amputation, that again increases the risk. Foot deformity, which is most commonly due to Charcot's arthropathy and callus formation, smoking. Of course, your poor glycemic control will be a key predisposing factor, or whether patients have got coexisting complications, like both the macro and microvascular complications, and of course, patients who are on dialysis. So these are the common key risk factors for developing diabetic foot ulcers. Okay, question 2. So this is a 58-year-old lady who was commenced on high-dose prednisolone therapy after she was diagnosed with giant cell arteritis. invariably steroid therapy carries risk of a lot of complications. So in these circumstances, which is the most appropriate treatment for prevention of steroid-induced osteoporosis? So your choices are bisphosphonate therapy, raloxifene therapy, hormone replacement therapy, calcium and vitamin D supplements, or salmon calcitonin therapy. So 10 seconds for you. Steroids invariably carry a lot of complications. So the gastrointestinal complications, bone complications. So when we put on patients on long-term steroids, every aspect has to be covered. And osteoporosis is one of the key complications relating to steroids. So hopefully you have marked your answer. So the answer is actually A. So that is bisphosphonate therapy. Now, glucocorticoids have got a very significant number of actions on bones. It has got action on growth mediators, inflammatory mediators, but the key action is that it reduces osteoblastic action. So the bone formation is impaired, and it increases osteoclastic activation. So it facilitates bone destruction. The National Osteoporosis Society here in the UK has recommended that the most appropriate treatment to prevent steroid-induced osteoporosis is actually a bisphosphonate. So your common drugs which are prescribed will include alendronate, ibandronate, risedronate, zolendronate, or etidronate. So any of the drugs that you can, depending on what sort of EGFR the patient has, whether it is permissible to use it or not. Now, they are the only classes of drugs which are shown to offer osteoprotection when used with concomitant steroid therapy. And you would consider the medication for anybody whom you recommend taking prednisolone more than 7.5 milligram in excess of 3 months. So it could be for any reason, whether it is given for rheumatoid arthritis or a giant cell arthritis or lupus or any chronic skin condition, any vasculitis. So anybody who has been prescribed for prednisolone more than 7.5 milligram for a period more than 3 months should be offered bone protection. Hormone replacement therapy would not be appropriate for in this patient because she's postmenopausal and she's at least 10 years postmenopause free from menopausal symptoms. Otherwise, we would have considered hormone replacement treatment. So bisphosphonates is the answer. Okay, question 3. I'll just keep an eye on the chat box to see if anything's there. Okay, nothing. So a 43-year-old lady presented at the endocrine clinic invariably for asking for treatment to prevent osteoporosis. So she was 1 year postmenopausal and experiences hot flushes at night and has a strong family history of osteoporosis. So you can see she's not in the 50 bracket. She's probably has got an early menopause because there is strong family history. And she is very worried that she might develop osteoporosis very soon. So which one of the following therapies would be most appropriate for this person? Whether you will give some estrogen supplements, either as oral or transdermal preparation, whether you give the person cyclical estrogen and progestogen, whether it is a bisphosphonate and calcium supplement, whether you give the person calcium and vitamin D supplements, or you will give a monoclonal antibody like denosumab as 6 monthly intervals. So 10 seconds for you to mark your answer. Read the question carefully, read the age carefully, read what she is experiencing at the moment and what we are trying to achieve. Okay, I hope you marked your answer. So answer here is actually B, so UK. Ten seconds. Okay, so the answer here is C, which is a fire engine driver. So in the UK, patients with insulin-dependent diabetes would not be able to do the following jobs. They cannot enroll to go into the armed forces, working on ships, can't be a pilot, can't be a policeman or a policewoman, can't be a fireman. They cannot be driving for post office or driving HGV vehicles. It is not LGV. So HGV vehicles are those large trucks more than 7.5 tons. The LGV vehicles, they can still drive, but some councils in certain parts of the UK does not permit them even to drive taxis. So starting of insulin in patient with diabetes has got professional implications in the UK. The details are very much given on the DVLA website, that which are the professions you can't do, or even if you have a heart attack, if you had a stroke, If you are a trauma or if you have a transient loss of consciousness or a fits, what are the limitations on driving? So please go through the DVLA website. This is all given. So details on it is recommended that patients with insulin-dependent diabetes should not drive emergency vehicles, and a fire engine is an emergency vehicle, or vehicles of public interest. So they may not be allowed to drive buses as well. And this is regardless of their glycemic control and hypoglycemic awareness. Full details are all given on the driver and vehicle licensing agency or DVLA website, and it invariably comes in exams. That if you have these type of illness, what are the ones that you can't do? So I come to the end of the 20 questions. We have already done for 1.5 hours. So if you guys have anything to ask me.
Yes,
please.
Dr. Das, thank you very much. And also special thanks to Dr. Patra and Dr. Darang, and also the rest of the participants. So since the session is ending, participants, I'd request you to have your doubts cleared up if you have any by asking Dr. Das. Thank you.
Hi, Doctor. Good evening.
Hi, who's this?
Yeah, I'm Dr. Darang.
Yeah, go on.
Yeah. Doctor, can I ask you something which is not related to the MCQ we solved, but related to endocrine? That would be DKA / eugenic,
Euglycemic.
Euglycemic DKA and HHS, HONC. How to differentiate these three based on labs / ABG or ketones? Yep.
So my diabetes slides, have you gone through all the endocrine slides I put up? Yeah, my diabetes slides have not arrived as yet, so I will put up that. But I will tell you, the fundamental of euglycemic ketosis is that you will have your blood glucose range in the normal range, so anything below 14. But in a classical type 1 diabetes leading to DKA, which is hyperglycemic ketoacidosis, the blood glucose level will be much high. The ketone levels will be high. So any ketone level in excess of 0.6 millimoles per liter, but invariably they have higher levels, more than 1.5 to 3 millimoles per liter. And of course, they will be acidotic. So classical triad of a hyperglycemic DKA would be raised blood glucose, acidosis, evidenced by low pH and low bicarbonate, and of course, elevated ketones. Euglycemic ketosis tends to happen in people who take SGLT2 inhibitors like your DAPA, CANA, or empagliflozin. And you will have to keep an eye that the blood glucose there would be mentioned in the normal glycemic range. So anything that should be below 11 or even up to 14. But the rest of the parameters will be same. So they may still have ketone bodies, but the clue will be there. The clue will be there that this is a person who has been taking probably an SGLT2 inhibitor, now comes systemically unwell with the blood glucose being in the normal glycemic range, but there is evidence of ketosis and there is evidence of acidosis as well. In contrast, the hyper HHS or hyperglycemic hyperosmolar state, the clue would be, again, this person is a type 2 rather than a type 1. And you will have to, if the calculated serum osmolality is not given, you have to do it. So these people, in contrast to type 1, will have a very high blood glucose level. So anybody who is given as a STEM that the blood glucose in the type 2 diabetes is more than 25 millimoles per liter, invariably your first job would be to calculate the serum osmolality. So if you remember your biochemistry equation, 2 times sodium plus potassium plus glucose plus urea, and if the calculated osmolality is in excess of 320 milliosmoles per kg, plus a very high blood glucose level, plus if the patient show evidence of dehydration as evidenced by raised urea, raised creatinine or hypernatremia, then the diagnosis of HHS is made. Otherwise, it may be a simple hyperglycemia in type 2. The STEM would be invariably that the patient is systemically unwell, the patient was taking 3 different drugs, now presents with very high blood glucose. But if you are seeing that the numbers are in excess of 25 and you're thinking that the osmolality should be high, because the blood glucose cannot be given in isolation. They will also give you the urea, creatinine, sodium. So if there is evidence of dehydration as marked by high sodium, high urea, high creatinine, and the patient is hyperglycemic, your first job would be to calculate the serum osmolality. But these patients will not be acidotic. But some patients can present with a mixed picture as well with HHS and DKA. If you have very high blood glucose, that can lead to acute glucotoxicity. So it is like a myocardial stunning. So if you suddenly stop the blood supply to the heart, you will have a ventricular fibrillation. Very similar. If you expose the pancreatic beta cells to very high blood glucose level, all of a sudden they stop functioning. So you will have a picture which is HHS, but invariably because there is no insulin, the patient will also invariably have diabetic ketoacidosis, which is called acute glucotoxicity. But that question would not be given in type 1, in part 1. That will be too complex for you guys. But I think it's better just to keep an eye about hyperglycemia with coexisting hypernatremia and evidence of dehydration, and then you calculate the serum osmolality. If it is given well and good, the cutoff number is 320 milliosmoles per kg. So anything less than that is hyperglycemia, anything more than that is HHS. Is it okay?
Do we need to keep an eye on the ABG or the VBG sodium?
Invariably, anybody who comes with a high blood glucose in the UK will have an ABG, invariably.
Okay, so will the bicarb be a pointer, doctor? Like, will it be less than 15 in case of DKA?
No, if it's a DKA, yes, of course, the bicarb will be low. Your body will start to compensate if there is any acid.
Okay.
So all your ketone bodies are acid. So body will use the buffer to neutralize that. Okay. So invariably, to maintain the pH in the normal range, the bicarb will start to drop. So you will have an acidosis and a low bicarb.
Okay.
And when you manage the patient, that is one of your key targets. So when you put the patient on fixed dose insulin infusion, and then you're setting up metabolic targets that when do I make a transition to a variable rate or a basal bolus subcut regime, bicarb is very important. You have to have a pH of more than 7.34. Your ketone bodies have to be less than 0.6 millimoles per liter, and your bicarb has to be more than 18. Before that, we don't make a transition to subcut insulin. No.
All right. Okay. Thank you, doctor. Thank you.
Invariably, if you get a stem on hyperglycemia, either in type 1 or type 2, you will have ABG given, and you'll see the renal function as well. So you keep a very close eye on whether the patient is acidotic or not, whether the patient is ketonemic or not, whether it is just ketonemia or ketoacidosis or not together. But if the clue would be in a type 1 or a type 2, so type 1 could be either a hyperglycemic decay or a euglycemic decay, because we do use SGLT2 inhibitors in type 1 as well these days for obese type 1. So,
right.
But I doubt whether euglycemic will be given in part 1. I doubt. But it is better to know that you can still have DKA even if your blood glucose is in the normal range, and that is principally due to the effect of counter-regulatory hormones. Because once you give drugs like SGLT2, your insulin requirement comes down, and your glucagon start to fire big time, and that is what the fats get broken down. Okay.
Thank you. Yep. Thank you. Thank you so much.
Yeah. Anybody else?
Good evening, sir. Dipendu here.
Yeah.
Please, I have a confusion in hypoparathyroidism. What is primary and pseudo hypoparathyroidism? What will be the difference in character also?
It's well written in textbook. In primary hypo is due to invariably lack of secretion of the hormone itself, and pseudo is when you have the hormone okay, but it is the receptor which is not binding to it, or it is the cascading reaction that is not happening. So if you have a gland which is producing adequate amount of hormones, but it has to bind to a receptor, and then you have a cascade of reaction that takes place intracellularly. So if that doesn't happen, then it is a pseudo condition because the gland is not at fault. Okay. So in those circumstances, you can say this is due to receptor resistance or due to molecular defects. So that is a pseudo condition because the gland is not at fault, but the metabolic action of the hormones is not happening because of improper binding to the receptor, or there is a failure of cascading reaction. So that is the condition why it is called pseudo.
Thank you, sir.
Okay, but yeah, it comes in exam, so it is all given in the endocrine section. So please read through it properly because these will be there. Part 1 pseudo will be there. Yeah.
Okay, sir.
Okay. Anybody else? Okay, so if anybody.
Yeah, so with that, I think we should.
Then I think we should wrap it up. Okay,
yes.
So
thank you, Dr. Das.
Thank you for listening patiently. I hope these questions have been of some help, and I think the recording will be available to you at some point.